And so all panelists will be visible on the screen, but I will spotlight the presenter so that they'll be front and center. If you don't want to be shown at the top, you can turn off your camera. It's always nice if you keep your camera on, but that is up to you. And I'll be in the background, so if you have any technical issues, just feel free to chat me and I'll help them. All right. Are we good to go live?
Yeah, let's do it. I'm going to share my screen now.
Perfect. And I will disappear into the background. Okay. I'll wait till you share your screen, Dr. Cooper, and then I'll go.
All right, there we go.
Perfect. Okay, I'll start the webinar now and just maybe wait 20 seconds for people to file in. And we're live.
Good evening, everyone. We'll be starting our webinar in the next minute or so. Well, good evening, everyone, and thank you very much for joining us for the Canadian Foundation of Infectious Disease webinar entitled A Liver Disease Workshop for Infectious Diseases Specialists and Trainees. I'm Dr. Curtis Cooper. I'm an infectious disease specialist from the University of Ottawa, and will be moderating our academic talk this evening. I'd like to welcome our four speakers: Marco Puglia, who's a hepatologist from McMaster; Carla Coffin, also a hepatologist from University of Calgary; Dr. Philippe Laglace-Wins, who's a med micro from University of Manitoba; and my colleague Ariane Buchan, who's infectious disease from the University of Ottawa. So I'm grateful to the four of you for dedicating an evening and much more time putting together what I anticipate are going to be very high caliber talks on a topic that, at least for me, has always been of great interest, is the intersection between the liver and infectious diseases. There we go. Just a word about CFID. Our mission is, as a charitable organization, we're committed to improving the health of Canadians and people worldwide through the support of research and dissemination of knowledge pertaining to the prevention, diagnosis, control, and treatment of infectious diseases. I encourage you in the audience to learn a little bit more about us at our website. And we're always happy to hear from you if you'd like to send us an email. These are the members that make up our board. Sherrick Hayter is our current president, and we just have a fantastic group of individuals that work very hard on behalf of the foundation. I want to highlight what I think is the most important thing that CFI does, and that is that we offer a collection of funding support for trainees in their pursuits of becoming independent academic researchers. So again, I encourage you to go to our website and learn more about the awards, and including for the first time this year, travel support for participating at AMI. I'd like to thank very much and recognize everyone who's helped with this evening's webinar. In particular, AbbVie for providing sponsorship to CFID so that we're able to put on this event. I'd like to thank Stanley Park and Lauren in particular, who has helped with the logistics of putting this on. You guys are really great to work with. AMI Canada, as always, a fantastic partner. So thank you for promoting. And I want to remind everybody that AMI is just around the corner in Vancouver. It's a hybrid meeting of virtual and in person from April 6th to 9th. Hearing that all the cool people are going to be there, I registered myself this just today. So I look forward to seeing many of you there. Also like to thank the Canadian Hepatitis B Network under the leadership of Carla Coffin, who we'll hear from later on, for their assistance with promoting this event. Also to CASL for their promotion, and to the CARA, the Canadian Association for HIV Researchers, who also helped with promoting this evening's events. Just want to once again mention 3 of the key supporters of CFID over the last year or so, and few of the activities that we were able to put on could happen without their consistent support. Our format is as follows. We'll hear from Marco first, who will talk about liver disease as a primer for those of us in infectious diseases. Carla Coffin is then going to cover viral hepatitis. Philippe Laglace-Wiens will then, after a break, we'll talk about some of the parasitic infections that affect the liver. And then Ariane Buchan as our expert in transplant infectious disease, we'll talk about transplant infectious disease involving the liver. And then we will have about 20 or 30 minutes right at the end for a panel discussion. And we'll be happy to discuss any of the questions that you are encouraged to pose. You can just go to the Q&A section and enter your questions as we go along. My own disclosures, I work with a number of these companies in research and for program support and as a speaker. And with that, I'd like to begin. So let's start with Marco, who is one of my friends and colleagues from McMaster in the Department of Hepatology and Gastroenterology. He's an associate professor there, and his focus is on medical education, as well as liver disease, including cirrhosis, NASH, PSC, PBC, and of course, hepatitis C. So please take it away, Marco. I will stop projecting on the screen, and you can try to project your slides.
Thanks, Curtis, for the introduction and the invitation to speak. I'm going to assume that everyone can hear and see me and my slides. If not, if someone could just let me know, that'd be great.
Yeah, we can see the slides.
Okay,
they look great.
perfect. Okay.
You can see you. You look great.
Well, I wouldn't go that far, but thank you. Thanks again for the invitation. I'm really looking forward to being part of tonight's event and listening to these great talks. I hope that this talk is relevant to the audience. I was asked by Curtis to give a talk on non-viral liver disease, a primer, so to speak. So I chose 2 of the more common liver diseases that I think all of us will encounter regardless of what area of medicine we practice. So non-alcohol fatty liver disease and alcohol liver disease. I'm just gonna start my timer here so I don't go over. There we go. Okay, so these are my disclosures. I've worked for, with, and for a lot of the these companies listed, but I don't perceive any conflict of interest with today's discussion. So we'll jump right into the NAFLD or fatty liver primer. So this is the outline for this evening's discussion. We're going to just try to go through pathogenesis, prevalence, risk factors, screening, diagnosis, and management in this 25 minutes or so. So we'll start with pathogenesis and prevalence. I think everyone's probably reasonably aware that at the center of the development of fatty liver disease is insulin resistance. And this is very much dependent on a fat supply which exceeds adipose storage capacity and causes insulin resistance at various levels, including at the level of the adipocyte, leading to fatty liver. I'll get into this in a little bit more detail in a moment. And then, of course, insulin resistance is associated with a number of other conditions, which are both risk factors and associated with fatty liver. Taking a slightly closer look, from the previous slide, we have adipocytes, which are becoming stressed in the sense that there's an excess delivery of dietary fat and an excess production of fat from sugars, and particularly in persons who are diabetic or overweight. At the level of the adipose tissue, there is insulin resistance, which causes net lipolysis and efflux or production of excess fatty acids, which go to the liver and basically get the process started. So the development of steatosis, or simple fat accumulation within the liver. From there are many steps. This is obviously a bit of an oversimplification, and many of the steps are poorly understood. But one of the important players would be hepatic lipotoxicity, from an increase in lipotoxic fatty acid derived metabolites, which causes mitochondrial dysfunction, endoplasmic reticulum stress, activation of inflammatory pathways leading to to superimposed hepatitis, so-called active steatohepatitis. And then from there, like any process which causes chronic liver inflammation, this can lead to hepatic stellate cell activation and production of fibrosis, and then eventual development of liver cirrhosis, and then complications thereafter. At the bottom of this slide, you can see various boxes here, which is basically just to give you an idea that there are a lot of medications and different interventions hitting different parts of this pathway or cascade, which at some point we hope to be important players in the management of this condition. So why am I talking about fatty liver disease at an infectious diseases meeting? Well, because it's in all of our practice. It's very, very common. There are estimates from various parts of the world. This is from the United States, where this is the worldwide prevalence, where the estimate is about 25% of the world might have fatty liver disease. But this is the first stage of fatty liver disease, just bland, simple steatosis, where there's fat in the liver with trivial or no inflammation and no hepatocyte damage. From there, a smaller proportion, thankfully, 3 to 5% of the worldwide prevalence of steatohepatitis. So the next stage in the disease, where there's inflammation, where there's fatty infiltration and inflammation and hepatocyte damage. And then from there, a smaller fraction still, but a very large absolute number, 1 to 2% prevalence of advanced fibrosis and cirrhosis, or these are patients on their way to becoming cirrhotic. So you can imagine the morbidity and mortality associated with this in absolute numbers is huge. If you think about Canada, where maybe 25-30% of the population has fatty liver, that's about 10 million persons. And if you do some simple math, we're talking about 100 to 200,000 people who are at risk of advanced fibrosis and cirrhosis. So this becomes an enormous health burden. In terms of the prevalence in certain high-risk groups, if I draw your attention to the right side of the slide, what you could see is persons, these are adult, this is analysis from adult patients in the US, 664 patients, and those who were diabetic with BMIs greater than 30 and hypertensive. The prevalence was almost 75% of them had fatty liver. And what's even more impressive or worrisome is that almost 50% had NASH. This analysis didn't look for advanced fibrosis or cirrhosis, but if you compare it to the number I showed a few slides ago, where the worldwide or where the prevalence in the general population might be about 3 to 5%, you can see how enriched this patient group is diabetic patients with elevated BMIs and hypertension for NASH. And so these patients are potentially on that slippery slope to a more advanced fibrosis. And it's really these patients in the liver world that we're most concerned with. These are the patients who are going to potentially develop complications of liver disease, and who, from a hepatology point of view, are the patients that we want to identify and manage. I don't have the slide, the data to show this, but suffice it to say that the degree of fibrosis is really the key determinant in long-term outcomes from a liver point of view in patients with fatty liver disease. So it isn't when the number one cause of death in all patients with fatty liver is cardiovascular disease. But once patients develop advanced fibrosis and or cirrhosis, then their risk of dying of liver disease or developing serious complications of liver disease increases substantially. So it's really these patients with advanced fibrosis that we want to identify. And we know that persons with type 2 diabetes have some of the highest risk of advanced fibrosis. So we really want to be focusing on these patients to identify excuse me, those at risk. So in terms of risk factors and screening, there are several guidelines as to who we should be screening for NASH, but not just NASH, NASH and advanced fibrosis. And here we have snippets from the American, European liver societies, as well as the American Diabetes Association. Without going into all the nitty-gritty details, essentially all of these statements are focusing on type 2 diabetic patients. And it should be these patients that we're looking for NASH and in particular advanced fibrosis. So how do we do this? It's easy, right? I mean, we have liver enzymes, we have ultrasounds, they must be helpful in making this diagnosis. Well, not really. ALT is neither indicative nor predictive of NASH or fibrosis stage. So in other words, a normal ALT does not exclude the diagnosis, and an elevated ALT does not predict the presence of NASH, advanced fibrosis, or predict the likelihood of progression. And neither ALT or AST is very sensitive for this condition. So although an abnormal ALT may often be the reason we're working a patient up, in and of itself, it does not have any ability to diagnose this condition or predict who is going to run into trouble with it from a long-term, in a long-term manner. So ultrasound, again, this is how we often get patients referred to us. Patients had an ultrasound for any reason, and they find incidental evidence of liver steatosis. And while it is reasonably good for diagnosing or detecting fat in the liver, it really has no value or role for detecting steatohepatitis, NASH with advanced fibrosis, or even cirrhosis, especially in the early phases. In the advanced phases, when the horse has sort of left the barn already, an ultrasound can be pretty specific in terms of when it identifies a small shrunken nodular liver. But we want to identify these patients before they're frankly cirrhotic and decompensated, and an ultrasound doesn't really help. A negative ultrasound, incidentally, doesn't entirely exclude fatty liver either. So if ALT and ultrasound are not that effective, then what tests do we have to try to identify not just fatty liver, but that patient with fatty liver and advanced fibrosis? So we have some real simple, well, first off, liver biopsy is the gold standard, but of course we want to avoid that for lots of reasons. It's invasive. We have millions of patients. We can't biopsy all of them. It's not really practical in terms of serial investigation. And of course, there's sampling error. So we need better non-invasive tests. And we have a bunch of them listed here. Fibrosis 4 score and NAFLD fibrosis score are simple scores which use clinical and or laboratory investigations. Fibrosis 4 score, for example, AST, ALT, age, and platelets. And it's most useful based on its high negative predictive value for excluding advanced fibrosis. So below a certain lower level cutoff, it can exclude advanced fibrosis with a pretty good degree of certainty. Negative predictive values of greater than 90-95%. Similar to NAFLD fibrosis score, which has the advantage of that it was validated in fatty liver patients. but the slight disadvantage is that it's slightly more complicated to calculate. But they essentially work interchangeably, in my opinion. The proprietary tests I'm going to leave alone. They're not really useful for clinical practice currently. The imaging non-invasive studies, the one you may have heard of, FibroScan, similar to the fibrosis 4 score and NAFLD score, has a very high negative predictive value. So very low scores. Actually, I should take a step back, sorry. But a transient elastography or FibroScan is an imaging technique that measures the stiffness of the liver. The stiffer the liver, the more fibrosis potentially in that liver. So a very non-stiff liver or soft liver, in particular below a lower cutoff of about 6 kilopascals, has a very high negative predictive value to exclude advanced fibrosis. So both of these, all of these tests are very helpful in excluding patients with advanced fibrosis. And I would put to you that FibroScan is fairly useful for making the diagnosis of advanced fibrosis and cirrhosis as well. Although one of the Achilles heels with all of these tests is that there is a fairly large indeterminate area that we have to contend with at times. And FibroScan sometimes overestimates the liver stiffness in these patients. So these tests are very helpful, but they're not perfect. And probably the biggest issue with FibroScan is its availability, or depending on where you're practicing, lack thereof. So that can be a challenge as well when you try to incorporate it into your clinical practice. The other imaging modalities mentioned here are even less available. And so I'm not going to focus on those. In terms of management of NASH, I don't think this will come as a major surprise to everyone, but weight loss is recommended by all societies. Most of the evidence suggests that if you can target weight loss of at least 7 to 10% of body weight, that there can be histological improvements, even fibrosis improvement. How you achieve that is really the billion-dollar question. It's pretty obvious that if you can attain a 500 to 1,000 kilocal energy deficit per day, that you're going to lose weight. But the problem is, how do you do that? Perhaps a Mediterranean diet, high in vegetables, low in processed foods, a lot of olive oils, for example. Of all the diets, this one probably has the strongest evidence. But really, at the end of the day, we don't know what the perfect diet is, or if there is one that a sort of one size fits all. We know for certain that that processed foods, added high fructose corn syrups are very diabetogenic and increase the risk of obesity and fatty liver. So avoiding those is probably very good advice. Other than diet and exercise, the latter of which helps to reduce hepatic steatosis to achieve weight loss, we are seeing more and more patients resorting to bariatric surgery, in particular those with solid indications. Although, to be clear, NASH is not an indication in and of itself for bariatric surgery. And then weight loss pharmacotherapy like GLP-1 agonists, SGLT2 inhibitors are becoming more commonplace these days as well. So this is just a reiteration of what I mentioned about the more weight you lose, the more improvement one can get from a histological point of view, including fibrosis regression. The biggest issue, however, is on the end of this column, where if achieving weight loss is difficult, sustaining that weight loss is even more difficult. And less than 10% of people in this analysis were able to do so at 1 year. But this study shows that if you can lose weight, in this case, these are patients who underwent bariatric surgery, the maintenance of weight loss, not surprisingly, was very impressive. And these patients over time had major weight loss, and this resulted in resolution of NASH in the majority of patients. And in addition, there was an improvement in fibrosis stage as well. So this, again, in a well-selected patient, could be a very attractive option for management of NASH, although again, it's not indicated solely for that purpose. This is another way of looking at the treatments currently available for NASH. We talked about weight loss. I'll just mention again that with drugs like semaglutide, for example, a GLP-1 agonist with Health Canada approval for management of diabetes and weight loss seems to be very helpful, although I'll be very clear that there is no Health Canada approval or indication for this drug in NASH to treat NASH alone yet, although it's in clinical trials. The other and real important point here goes back to what I said a few slides ago, which is that the number one cause of death in patients with fatty liver is cardiovascular disease. So aggressive management of metabolic risk factors is very important, and this may include a statin if indicated. The important point here is that there is no contraindication to the use of statins in patients with NAFLD. There's no increased risk of statin-induced drug liver injury. There are some drugs that can be used off-label. I'm not going to have time to go into this. Vitamin E and pioglitazone, there is some evidence for their use in biopsy-proven NASH. We could talk about that in the question and answer if people have questions. The magnitude of that benefit, in my opinion, is not great. These aren't drugs that we're really relying on, in my opinion. And the last slide for the NASH part of this is just nothing for you to memorize. But if you remember that one of the first slides I showed with all those different targets, these are just a small list of all the different of many of the different medications that are currently in various stages of clinical trials that we may have in our tool belt at some point down the road, on top of what I believe is still going to always be the cornerstone of treatment, which is managing the metabolic syndrome with diet, exercise, maybe pharmacotherapy, maybe bariatric surgery. So that was a very quick summary of NASH. I'm going to move on to an equally quick summary of alcohol-related liver disease, and then, of course, happy to take questions later on. The outline here is a bit about terminology, which I think is important. We'll talk briefly about alcohol use disorder, and then alcohol liver disease, specifically alcohol-related hepatitis. The first slide here is just to sort of hopefully a reminder. I'm not sure, if this information has been disseminated widely, but we're trying to avoid the use of the word alcoholic. Having alcohol-related issues is stigmatizing enough. The word alcoholic really has a lot of negative connotation. It's further stigmatizing. So we really want to be using the word alcohol use disorder instead of alcoholic, and then instead of alcoholic liver disease, alcohol-related liver disease. Small changes, but I think these are powerful ones, in my opinion. Alcohol-related diseases are very important. From a public health point of view, more than 3 million deaths per year related to alcohol, almost 140 million disability-adjusted life years. And most of these deaths related to cirrhosis, but also injuries, cardiovascular disease, cancer. What's the safe amount of alcohol? I would say that we actually don't really know what the answer to that is, but in terms of reducing the risk of developing cirrhosis, the recommendation typically is limiting to less than 2 standard drinks per day for women and less than 3 standard drinks per day for men. Although, does that absolve any risk? Does it reduce the risk of other alcohol-related complications? That's less clear. We should all be screening, in my opinion, for alcohol use disorders because, these patients are everywhere. They're not just in the hepatology clinic or just in the primary care. They'll be in your infectious disease clinic, of course, on your CTUs if you're covering medicine. And it's so common, we should be screening for it. There are a lot of tools. The one in particular I like is Audit, or Audit C in particular, because the Audit C version is much shorter. It's just these first 3 questions. I think most of us probably do this anyways in some way, shape, or form, but this is a very well validated tool. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you are drinking? And how often do you have 5 or more drinks on one occasion? And so these questions explore consumption. And if the score is greater than 3 in women or 4 in men, then it suggests that they may have an alcohol use disorder. The other questions here, which I'm not going to go into, assess dependence and alcohol-related problems, which of course you can go into if the initial screen is positive. Managing alcohol use disorders, well, this is not going to be a shocker. The most important intervention is alcohol abstinence. Achieving it is a different story, however, and it can be very, very challenging. Cold turkey works for some, but for most it does not. Most of the data would suggest combination therapy with non-pharmacological therapy, psychosocial, cognitive behavioral therapies on top of potentially pharmacological therapy. What I think is a very important point is the fact that abstinence improves clinical outcomes at all stages of alcohol liver disease. So even in my patient in the paracentesis clinic who's floridly decompensated, when they stop drinking, they do better on average. Not all of them, of course, but certainly far more likely to have a better outcome, better survival than persons who continue to drink. And although this may seem obvious for some patients, it's not always that obvious. A lot of them feel as though, why stop now if I've done this much damage to my liver? What are the chances? And I share this type of information with my patients to help motivate them to stop, because it's almost never too late to stop drinking. Pharmacotherapy is important. This slide is not designed for you to memorize necessarily, but just as a concept. I didn't put the slide in, I should have actually. There's been a lot of studies, including a relatively recent one at a VA hospital, looking at the uptake of pharmacological therapy in patients with alcohol use disorder. And you might not be surprised to know that it's fairly abysmal. Of the patients who were offered alcohol use disorder treatment, pharmacological therapy, psychosocial therapies, or both, not surprisingly, they had much better outcomes in the long term. You don't have to be an addictions medicine specialist to prescribe these medications. I'm not suggesting that perhaps the people on this meeting are going to be doing this, but I think it is very important to know that there are therapies that are FDA and Health Canada approved, and where there is some evidence for the benefit of these types of treatments. So I'm going to flip gears the last few minutes here on alcohol liver disease, but specifically talking about alcohol-related steatohepatitis, or AH for short. So similar to NASH, alcohol-related liver diseases have multiple stages. So there's simple steatosis. If you go on a Caribbean vacation and drink for a week straight and you biopsy your liver, you're going to have some fat in the liver, but it goes away when you stop drinking. So it's not a chronic illness. With chronic, heavy, regular use of alcohol, the patient will develop hepatocyte injury, inflammation, and then of course that process can lead to liver fibrosis, liver cirrhosis, and then complications thereafter. I'm going to focus on alcohol hepatitis, and I just realized I put alcoholic hepatitis, which I shouldn't have. My apologies. So alcohol hepatitis, these are patients that especially if you're doing internal medicine, CTU, you're going to see these patients come in. They're patients who may or may not have cirrhosis, often do, but not always, who come in with recent progressive jaundice, typically, often associated with fever, malaise, neutrophilia. They look like they could have infection. Many of them do, in fact, and you have to have a high index of suspicion for that. They typically have hyperbilirubinemia, obviously, if they're jaundiced, and AST higher than ALT. So these are tip-offs that this person probably has alcohol hepatitis. And it's really important to make this diagnosis because the short-term mortality of these patients could be considerably high, especially if it's unrecognized and untreated. So how do we manage these patients? So alcohol abstinence, obviously when they come into hospital, they typically become abstinent, which brings up other issues like alcohol withdrawal. And so screening and managing that's very important. B-complex vitamins, like thiamine, for example, especially given the risk of Wernicke's encephalopathy. Some of these patients can even have refeeding syndromes because they're very malnourished. So you have to be on guard for that as well. Manage their complications of decompensated liver disease and determine the severity of alcohol hepatitis. There are a number of ways of doing this. The Madri's discriminant function is the probably longest standing tried and true one, that it's dichotomous and it suggests that patients are either severe or not severe, and same with the MELD score cutoff of about 18 to 20. So if you make a clinical diagnosis of alcohol hepatitis, the most important two initial interventions would be assessing their disease severity, as I just mentioned, but immediately focusing on nutrition. These patients are often very malnourished. Look out for refeeding syndrome, high caloric diet, 35 to 40 kilocalories per kilo per day, high protein intake, 1.2 to 1.5 grams per kilo per day. They don't need TPN. If they can eat by mouth, that's the best way to do it. If they need an enteral tube, so be it, because nutrition is that important. I'm almost done here. I'm going to run over by a minute or so, sorry. So once you decide that a patient has severe alcohol hepatitis using the Madri's discriminant function or MELD score, the standard of care would be prednisolone or prednisone, and then an assessment of improvement using something called the Lille score at day 7. And this is very important. If the Lille score suggests that they are not responding, then their outcomes are potentially very poor. Continuing corticosteroids puts them at risk for complications, namely infectious complications. And because of that, these patients should have their prednisolone discontinued at that time if their Lille score suggests the absence of a significant improvement. If they are improving based on the Lille score at day 7, they should continue treatment for at least 28 days and then potentially taper after that. Again, not going to go into a lot of detail here, but there are a lot of novel agents looking at different targets to treat alcohol hepatitis, from looking at the gut microbiome to anti-inflammatory medications to anti-fibrotic medications. There does seem to be a pipeline here that we may be able to take advantage of down the road. And the last, I think, slide here is about liver transplant. Obviously a talk in and of itself, but I just wanted to stress that there's been a push over the last couple of years to de-emphasize the 6 months of abstinence criteria as the sole criteria to determine if someone is a candidate for liver transplantation with alcohol liver disease. So these patients are, should not be excluded from transplant based on the 6-month criteria alone. And the new criteria are really focusing more so on a comprehensive psychosocial medical assessment rather than solely relying on 6-month criteria. And these are just my take-home points here. NASH is common. Insulin resistance plays a central role. Diabetes, obesity are the most important risk factors for advanced fibrosis. The degree of fibrosis drives liver outcomes. Non-invasive techniques are useful to help stage and risk stratify patients, such as FIB4 and FibroScan that I mentioned. Management should focus on metabolic syndrome and perhaps an increasing role for bariatric and pharmacological treatments for weight loss. And there's a deep pipeline. And for alcohol liver disease, let's try not to use the word alcoholic. We can screen for AUD using the Audit C. Psychosocial and pharmacotherapies are important to treat alcohol use disorder. ALD is in the spectrum of disease, and achieving abstinence is of paramount importance. Corticosteroids are used for severe AH along with aggressive nutrition, and liver transplant should be considered in these patients, especially when they fail treatment. And 6-month abstinence window shouldn't be the only criterion. And that's all I have, and happy to answer questions later on. Sorry for running a little bit over.
Nope, that was all good. Thank you very much, Marco, for covering what I think any physician would agree are critical things that we need to know something about. So that was bang on. So I'll ask you to stop sharing your screen, and I'll invite our next speaker, Carla Coffin from the University of Calgary, to speak. Just a brief introduction. She's a professor of medicine and hepatologist at U of Calgary. She's a basic scientist with a focus on immunology and liver disease, a clinician researcher, a clinician, educator, and a leader as well. She's leads our Canadian Hepatitis B network, which is just a fantastic collection of researchers from across the country looking at all things hepatitis B. So I've asked Carla to give us a in-depth review of viral hepatitis. So take it away, Carla.
Great, thank you. Can everybody see my slides? Is this all good?
Yes, we can.
And you can hear me okay. All right, so I'll jump right in.
Yes, Dr. Coffin, sorry to bother you. We can see you're in presentation mode, but in a different format. Do you have 2 monitors?
Oh, I do. Okay, let me.
We just need to switch the monitors.
Right. Okay.
You can do swap display right there at the top.
Swap display. Let me do this.
Our faculty has firmly established that none of us have a future in IT.
Is this better?
It's your mouse is on. Yes, perfect. Try.
How's it?
Excellent. Thank you very
Okay,
much.
excellent. All right, sorry about that. Okay. All right, so let's just jump right in. So these are my disclosures. So most of them are related to clinical trials that we do at the University of Calgary. and also funding from industry to the Canadian Hepatitis B Network. So as Curtis mentioned, so the goal of my talk today is just to review very briefly the major causes of viral hepatitis, and then to talk more about the new developments or what's exciting in the last couple of years in hepatitis B and in hepatitis C in terms of development of vaccines, what's new for the epidemiology of hepatitis A and hepatitis E, and also to review the new drugs coming through the pipeline to achieve a cure for hepatitis B and hepatitis delta. So I'll start with the enteric viruses or the foodborne viral infections. And I'm certainly not going to read all of this information that's provided on this table. It is more just for your reference. One interesting point I'd like to highlight about hepatitis A, and this is, I'd like to get your feedback if you want to throw something in the chat box, or we can talk later, is that with the changing epidemiology of hepatitis A, you know, with improved sanitation and so on, there are fewer children getting infected in which they would more likely to have a more self-limited or a milder disease course. So there's more older people or adults that are at risk. And especially with like the globalization of our food supply, perhaps this is something that we should be concerned about. And if you think about in our own population, and as Marco mentioned, if there's 25% of people living with fatty liver disease that could potentially be at risk for hepatitis A or another superimposed viral infection. So the US CDC has recommended that all children as well as high-risk adults get the hepatitis A vaccine, whereas our own immunization organization, or NACI, recommends only for high-risk individuals, not as a universal vaccine. So perhaps we should be considering this in our own childhood immunization series, and I'd like to get your opinion about that. So for hepatitis E, also a foodborne or fecal-oral transmission. Historically, in our sort of own understanding, you know, hepatitis E was considered to be mainly a disease or virus infecting third world countries or resource-poor regions. But I think there's an increased appreciation that we're underestimating the disease burden. And this has especially been highlighted in Europe, such that recently, for the first time, the European Liver Association has published new guidelines for management of hepatitis E. And in these guidelines, they highlight that there is a tremendous global burden. A recent systematic review and meta-analysis has reported that 1 in 8 individuals have had previous hepatitis E virus infection. And EASL highlighted the special zoonotic potential. So transmission from eating undercooked pork. Okay, I'm sorry guys, my lights just got turned off because it's after hours. Can you still see me okay? I have my own lamp.
No, you look fine.
Okay, great. So from eating undercooked pork, or even exposure from household pets, so from dogs. And thus, EASL has provided new guidelines about screening for hepatitis E, in that all individuals with hepatitis should be tested, even if they don't have a travel history, anybody presenting with drug-induced liver injury, anybody who has abnormal liver enzymes after receiving a blood transfusion. So you can think about that in our own hospitalized patients. I mean, how often do we see that? Do we routinely test for hepatitis E? They recommend that our blood donor services should be screened for hepatitis E. And I certainly don't think that that is routine. And they had special consideration for immunocompromised individuals who would be at risk for developing a chronic or a persistent infection in terms of risk factors and what they should do to avoid potential exposures and management. So I encourage you to sort of look at these guidelines if you haven't done already. So in order to address this sort of increasing global threat, there's been a recent development of a collaborative network where they're trying to develop a repository of sequence data from both humans and in animals with hepatitis E. And this is sort of noted here with the website link to that. So that's all I'm going to say about hepatitis A and hepatitis E. Just want to make 2 points, is that because of the global changing epidemiology of hepatitis A? Should we be expanding our hepatitis A vaccination program? And then also to increase awareness about the burden of hepatitis E, especially with zoonotic infections, and do we do enough screening? Okay, so moving on to bloodborne or chronic infections. So I'll start with hepatitis C, and certainly you don't need to review in too much detail for this audience about the virus and epidemiology and modes of transmission. We are all aware about the incredible success of the directly acting antiviral agents that are highly effective and pan-genotypic. And what I want to talk about today, or just bring up, is discuss the results of the recent hepatitis C vaccine trial. So despite the fact that we've got really good drugs, there's still many new infections of hepatitis C occurring globally, and it's important that we have a vaccine. So this very important study was published in the New England Journal of Medicine and led by Dr. Andrea Cox's lab. And it was a phase 1/2 randomized, double-blind, placebo-controlled trial. It included a so-called prime boost regimen with two types of vaccine, a recombinant chimp adenovirus with a modified vaccinia boost virus. Both of the vaccines encoded the non-structural proteins from genotype 1. They enrolled a very large cohort, so over 500 adults with a history of injection drug use, and compared them to placebo. The endpoint was individuals that developed chronic hepatitis C infection. So the vaccine studies show that there were no serious adverse events. It did induce HBV specific or hepatitis C specific T cell responses. And it also lowered the peak hep C RNA in those that are vaccinated versus placebo. But unfortunately, it did not work in that it did not prevent chronic infection or reduce or increase the rates of spontaneous clearance. So this is sort of data from the study in the vaccine and the placebo group, equal numbers, over 200 individuals recruited, but equal numbers developed chronic hepatitis C infection, so 14 in both groups. So when they were discussing why did this vaccine not work, potentially, could it be because of adenoviral vector viruses, which were less immunogenic? Maybe there's natural exposure to human adenovirus and thus development of cross-reactive antibodies. The vaccine included the non-structural protein, didn't include the hepatitis C envelope protein, and perhaps that's why it didn't work. And then finally, this is a difficult population in that you're enrolling people who inject drugs. Perhaps they had a risk of previous exposure to trace amounts of virus. Although they didn't develop an antibody response, perhaps they had a reduced immune response to subsequent infection or to subsequent vaccines. So this is a challenging population to recruit, and certainly the authors should be congratulated on the tremendous effort that went into doing this study. And future studies, some people are talking about maybe different approaches such as controlled human infection models, although the ethical and logistical barriers to that can be appreciated. So finally, for hepatitis C, I just want to put on my public health hat here and talk a little bit about the targets for hepatitis C elimination, and that we are not on track to achieve these targets for 2020 or for 2030. There's definitely a need for development of a hepatitis C vaccine. So the last part of my talk, hopefully I'm not going to go over time, I'm going to talk about hepatitis B and hepatitis delta virus co-infection. So this is another busy table about hepatitis B virus in terms of the virology and life cycle, which I'm not going to go into in any great detail, but want to have this here for your own reference. Hepatitis B has a tremendous global burden, which you guys can appreciate. The main risk is in mother to child or infant transmission, and that chronic infection develops in 95% of infants that are exposed without a vaccine. There has been an effective vaccine available for over 3 or 4 decades. There's also very good treatments for hepatitis B, although they don't cure. So the nucleoside analogs, they suppress the virus, but they can't clear. And in terms of new things that I want to highlight in this talk is the recent trivalent vaccine that has been used in adults, and also to talk about the hepatitis B cure pipeline. PHAC, or the Public Health Agency of Canada, recently updated their report on hepatitis B cases in Canada. It showed that the greatest proportion is in Ontario, followed by these other provinces, BC, Alberta, and Quebec. Other 6 provinces accounted for less than 6% of cases reported. Similarly, hepatitis delta virus, again, I have a table just to provide for your reference, the virology and the life cycle of the virus. Hepatitis delta is an interesting virus. It's the most severe form of viral hepatitis reported in humans. It's been called a satellite virus or a defective virus of hepatitis B. It requires the host RNA polymerases as well as the hepatitis B surface antigen in order to complete its life cycle. Thus, the hepatitis B vaccine protects against both viruses. There's no real good treatments for hepatitis delta, only interferon, which is very weakly effective, but there's a new treatment that's coming through the pipeline that I'll discuss more. And also I'd like to talk about some new epidemiology of hepatitis delta in Canada that we've conducted through the Canadian Hepatitis B network. And I'm sure Curtis is not surprised that I'm showing this slide and that I've been pushing a lot about the importance of the birth dose hepatitis B virus vaccine. In fact, I wouldn't even need to give a talk about HBV cure if we've been implementing greater global use of the birth dose vaccine. And I'm sure you guys are quite aware that most adults exposed to the virus develop a robust, innate, and adaptive immune response and spontaneously clear. In comparison, most children have a very weak immune response and are more likely to develop a chronic or persistent infection. The Hep B birth dose vaccine prevents liver cancer, even development in children. Despite that, Canada, there are still 4 or 5 provinces that only do the vaccine in pre-adolescence or at grade 5, including Ontario, our largest province, which, as I had already pointed out, has the greatest burden of hepatitis, chronic hepatitis B in Canada. So as I mentioned, that very happy to talk about a recent study that we've done through the Canadian Hepatitis B Network, highlighting the epidemiology of hepatitis delta virus in Canada. And I think that hepatitis delta is underappreciated in our population. Most of our guidelines, ASLD as well as CASL, they only highlight risk-based screening. There's not a universal screening. So this is a study that was conducted by Carla Oshway from the National Microbiology Lab, which is the only lab in the country to date that does hepatitis delta virus testing or hepatitis delta virus RNA. And she investigated the prevalence of hepatitis delta in referred specimens sent to the NML. And in addition to that, we did a cross-sectional study of patients enrolled in the Canadian Hepatitis B network that were known to be hepatitis delta virus co-infected. In the study, Carla found that nearly 5% of the referral population was hepatitis delta virus positive. That infection was highly associated with risk behaviors, which we'd previously reported in terms of intravenous drug use or substance abuse. There was many different genotypes or a wide range of genotypes that were detected in keeping with this sort of the broad geographical distribution of many of the patients with hepatitis delta. And also hepatitis delta was associated with much higher risk of progressive liver disease or cirrhosis. So highlighting the need for increased screening and surveillance in Canada. Similarly, a study that was published with in the US with the US veterans population showed similar results to the hepatitis B, Canadian Hepatitis B network in terms of risk factors such as substance abuse, end-stage liver disease, and other sort of laboratory parameters. So I think that this sort of highlights that perhaps we should be doing more universal hepatitis delta screening versus just risk-based. Okay, my lights are coming back on again. All right, so Another thing I want to highlight in terms of what's new for viral hepatitis is a new vaccine for hepatitis B. So the monovalent hepatitis B vaccine has been available for 30 or 40 years. And although it's been effective, there are certain groups of patients, especially adults that are certain risk factors that may have an impaired immune response. Adult hepatitis B vaccination is often overlooked. The CDC has actually recently updated their guidelines to recommend that all adults receive the Hep B vaccine. So in this study, so-called the PROTECT trial, was a large multi-center phase 3 study, and they compared a novel vaccine formulation, so a tri-antigenic recombinant vaccine versus a 3-dose standard vaccine that we're currently using. So this tri-antigenic vaccine was only 2 doses. It was given to all adults over the age of 18, and they found that it elicited a much stronger immune response, especially in those over the age of 45 or those with other chronic disease. And so perhaps that this could be an important sort of new vaccine to target a missed population and work towards our goal for achieving hepatitis B elimination. And the last bit of my talk, I want to highlight the exciting new developments in terms of new treatments under investigation to achieve a hepatitis B cure. So Hep B has a complex life cycle. The 2 things I want to point out about the virus is that it forms a reservoir called covalently closed circular DNA within the viral nucleus, which is very difficult to eradicate. The new drugs that are in the pipeline are trying to attack different targets of this life cycle, including blocking viral entry, targeting viral RNAs, targeting the viral capsid or packaging, as well as targeting export of the virus. The targeting for cccDNA, however, is probably not going to be happening anytime soon. That these drugs are mainly sort of more preclinical, less in development. And then secondly, another sort of key sort of approach is stimulation of the innate or the adaptive immune response to achieve HBV cure. So these, as I mentioned, these drugs are in several stages of development. Most of them are probably going to be about 5 years, phase 2, phase 3 studies. The cccDNA eradication is more preclinical, maybe about 10 years before we actually achieve the so-called holy grail. Most approaches are using a combination in that use a backbone of nucleoside analogs with interferon in combination with these other drugs. So we have a strong rationale for using immunotherapy for targeting chronic hepatitis B, in that natural infection or Mother Nature already clears hepatitis B by natural infection, and that adults are most likely to clear and develop protective immunity. The direct antiviral agents only target intermediate steps in the virus life cycle. If you stop, then the viral relapse occurs. The only way to clear HBV cccDNA is potential using the immune system to attack all viral particles and also to attack integrated virus. However, in patients with cirrhosis, there's high risk of precipitating liver failure with immunotherapy. So we're sort of walking a thin line in terms of trying to achieve viral control versus inducing immunopathology. So I'm going to talk about, these are all the different drugs that are in the pipeline for developing immunotherapy. I'm just going to talk about one because it was recently highlighted at the liver meeting, and that's the checkpoint inhibitors in order to restore CD8 T cells or reverse T cell exhaustion. So this was a phase 2 study in which they administered a checkpoint inhibitor in patients with hepatitis B on a nucleoside analog. So they had suppressed viral load. The primary endpoint was to achieve surface antigen reduction. In this study, they used a single subcutaneous dose of the checkpoint inhibitor, and they found that it did induce a dose-dependent surface antigen decline. and concluded that this certainly has potential for achieving a HBV cure in combination with the nucleoside analog, and they're planning to do further phase 2 studies. So moving on, just to chat about the directly acting antiviral agents. I already mentioned about Miraclude-XB, or a novel drug that's in the pipeline for hepatitis delta virus. I'll talk about the other approaches in terms of capsid inhibitors, antisense oligonucleotides or RNA inhibitors, and the surface antigen inhibitors, as well as, I'm not going to go into any great detail about the cccDNA or gene editing therapies because it's still preclinical. So Miraclude-XB, or bulevirtide, is a viral entry inhibitor. It targets the bile salt transporter for hepatitis B and hepatitis delta. There's been phase 3 studies published. And in these studies, they found that compared to placebo-treated patients, that delta co-infected patients had both virological, biochemical, and histological response. This drug has already received FDA or been conditionally approved by the European Medical Agency, and it's been submitted to the FDA for emergency approval or orphan drug status. The other new agent that was noted at the recent American Liver Meeting is the siRNAs, or antigen reduction. And they found in this study, it was a phase 2 study, which was shown to reduce surface antigen in patients with chronic hepatitis B infection. They enrolled virally suppressed subjects that were given the siRNA every 4 weeks for 6 doses. This showed, again, a decline in surface antigen at week 24. 3 patients actually achieved surface antigen below the limit of quantification, as well as anti-surface seroconversion. So these combined results is very encouraging, and hopefully moving forward with this agent. And then finally, I want to mention the siRNAs in combination with a capsid assembly modulator. This is another interesting study published at AASLD, which showed that this combination treatment was effective in reducing surface antigen decline over time. However, the capsid assembly modulator alone was not effective, and thus their company is probably just going to move ahead only with the siRNA. So in terms of take-home message for hepatitis B and hepatitis delta is that hepatitis delta causes the most severe form of virus-induced hepatitis in humans. Incredible, tremendous burden of hepatitis B, and if we implement a greater birth dose hepatitis B vaccination, would help reduce this burden. There's new data from the CDC showing that we should probably increase screening for hepatitis B for all adults. We need to increase linkage to care for those that are living with hepatitis B. And there's great hope for a cure, many promising drug candidates being developed, but it will probably be several years before we get to a HBV cure. So in summary, for viral hepatitis, I think we can all appreciate, and that's why you're here tonight, that we know it's a major public health threat. We need to do more for prevention of viral hepatitis, increase screening, treatment, and linkage to care. And there's a lot of research being done in terms of hepatitis E vaccine, new Hep B vaccine formulations, as well as Hep B and Hep Delta cure pipeline. So thank you, and I'm happy to take any questions at the end, and I apologize if I've gone over time.
You have not. You are in perfect time. Thank you very much for that overview of a lot of material in a very complex field, especially with Hep B and Hep D. So let me just share my screen here again. So we're halfway through our agenda now. So what I suggest we do is we take a 5-minute break. So I have, by my clock, I've got 8:04. So by 8:10, let's come back, and then it'll be Philippe's turn to educate us on something that at least personally I've always found a tough time keeping straight, or is liver disease and the intersection with tropical medicine and parasitology. So you've got 5 minutes, and then please come back. Okay, we'll get going in a minute or so. I will stop sharing my screen and give Philippe a chance to get all set up. How are you doing tonight?
Not too bad.
Good. I appreciate both you and Ariane taking time from your holidays to work on these talks.
Oh, no worries. You know how holidays often end up being for all of us,
Yes, I do.
especially these days when I still feel it can't really go anywhere yet.
True. Okay,
Right.
so welcome back, everyone, and hope you're finding these talks as interesting as I am. I encourage everyone in the audience to submit any questions that you might have. We'll save them all up for the end when we'll have a group panel discussion. With that, I'd like to introduce Dr. Leglace-Wiens from the University of Manitoba, medical microbiologist with a focus on antibiotic drug resistance, which I guess is no surprise as a medical microbiologist. I know Philippe very well for two reasons. One is for the years of service as a board member with the Canadian Foundation of Infectious Diseases. So it's good to see you. Philippe recently rotated off of the board, so thank you for your years of service. And then secondly, when I think about parasitology in Canada, Philippe is one of the first people that comes to mind for his expertise and his abilities to describe it in a way that makes sense. So with that, I welcome you and look forward to hearing what you have to say about parasitic liver diseases.
Thank you, Curtis. Parasitic liver disease is, of course, a big topic to go through in about 25 minutes. So I will do my darndest, and I will make my slides available for anybody who's attending, and they can review them at their leisure. I asked my family to come up with a joke about parasitic liver diseases, and what they told me is that you might pass an exam, but it would likely be a fluke, which I thought was amusing. I'm not going to read my whole land acknowledgement, but acknowledge that I work and live on Treaty 1 territory, and I acknowledge the faults of the past. And in the spirit of reconciliation, I work to move forward with Indigenous people. And I have no conflicts related to this talk. Just very brief outline. We're going to go through parasitic liver diseases just as a background, some common presentations, because there's a lot of consistency in the types of presentations that we see in parasitic liver disease. Going to talk about classification and taxonomy. I know it's the most boring topic of parasitology, but it is relevant. And some basic investigations when you see people who have suspected parasitic liver disease. Then I'm going to go through four of the most common ones. Certainly schistosomiasis is an important one, especially if you've got an immigrant population, echinococcosis, fascioliasis, and amoebic liver abscess. There is quite a lot more, but of course I needed to grind this down to a sharply focused lecture. So the liver is actually a very common site of infection for parasites that are ingested orally. Essentially, any parasite that can get through the lumen of the bowel will theoretically first encounter the liver, either because it's contiguous to those mucosal sites, or because it's the first site of portal entanglement, meaning that anything that gets into the bloodstream around the gut is likely to be brought to the liver. There are lots of parasites that affect the liver, and many of them do so indirectly. I'm not going to talk about those. Things like malaria and leishmaniasis, ascariasis, toxoplasmosis, many of them do affect the liver, but I'm going to focus mostly today on those that really directly affect the liver. Perhaps the most important primer in parasitic liver disease is to remember that the most important feature of diagnosing a parasitic liver infection is to identify potential exposures and geography. The beauty about tropical medicine is it's very geographic. You really cannot get a disease unless you are exposed to its vector or its reservoir or where it lives. So when you get a clinical history, it's actually most important to get that piece of information. Your symptoms and lab investigations are definitely contributory, so they are important, but they're not the starting point. The nice thing for those people who really hate the extensive physical examinations that they needed to do for their board exams, very rarely will the physical exam give you a lot of hints on parasitic disease, occasionally, but it's definitely not as contributory. So my one slide on taxonomy that I want you guys to remember is that liver parasites, we can divide them into a number of different categories. Cestodes, which are tapeworms, trematodes, which are flukes, nematodes are roundworms, and I'm going to skip right over them because none of them cause really primarily liver disease. Sometimes you'll get an occasional ascariasis that'll get stuck in a bile duct, but that's a minor presentation. And then protozoa, and there's really only one important one I'm going to talk about. It's Entamoeba histolytica. Among the cestodes, it's only Echinococcus that's the important one that I want everybody to bring home, is the tapeworm that causes important liver disease. All tapeworms have an intermediate host in which cysts form inside the intermediate host. Humans are an accidental intermediate host of Echinococcus. It's supposed to be sheep or mice or other rodents, but humans become an accidental intermediate host and then get these cysts forming in their liver. The flukes, schistosoma is the blood fluke. It lives inside blood vessels and causes its damage by laying eggs. And then liver flukes, which are primarily Fasciola, Clonorchis, Opisthorchis, and Mythorchis. Fasciola is the only one I'm going to talk about today. The others are bile flukes, and they don't tend to cause direct liver disease other than by occupying space in the bile ducts. Lung flukes are Paragonymous. Paragonymous will occasionally migrate through the liver and cause disease that way, but I'm not going to linger on it. So now you see why I've selected 4 different parasites, Echinococcus, schistosoma, Fasciola, and Entamoeba histolytica, for an overview of parasitic liver disease. So common presentations of parasitic liver disease. So anytime that you suspect a liver disease, you have to start with that travel and exposure history. I hinted at this before, but I cannot underscore how important it is to know where this person has been, what sort of exposures they have. In those exposures, there are things like food habits, get a dietary history, because many parasites have a preferred food association, a geographic exposure. It's really impossible to get schistosomiasis without being to a place where there is human schistosomiasis. An occupational history may be important because certain occupations are associated with liver disease caused by parasites. Sexual histories are even important, and I didn't put that there, but certainly men who have sex with men, for example, are at higher risk of getting Entamoeba histolytica infections. Another important point to make about presentation is that only the acute stage of parasitic infections tend to produce clinical liver disease. These stages are usually transient, they're usually self-resolving, and you do have to rely on the history and those exposures to get sort of down to the appropriate testing and imaging. Occasionally, you'll find an incidental finding of an abnormal liver disease, a cystic liver disease that you determine is Echinococcus in a completely asymptomatic patient. And that's that last point. Many infected patients will present chronically without any identifiable symptoms and only an incidental finding, as the one on the picture here of a echinococcal cyst. These are 4 important exposures. I told you that the exposures are really critical when determining parasitic liver infections. So if you can remember to ask these 4 questions, or at least think about them, you'll be well ahead of your peers in terms of diagnosis of parasitic liver disease. So accidental or deliberate ingestion of canid feces, and canids like coyotes, domestic dogs, wolves, foxes, or bears. This is a major risk factor for Echinococcus. And I say accidental or deliberate because most of the time it's accidental. The environment is contaminated with the feces and you accidentally eat them. This is why individuals who do foraging in forests, berry picking, are at slightly higher risk. And certainly individuals who work and live where there's a lot of intermediate hosts like sheep, camel, deer, mice, rodents. These would be, for example, pastoral farms, wild foraging, and hunting. Deliberate ingestion, of course, of canid feces is more likely in pediatric populations as an accidental / deliberate ingestion. Skin contact with fresh water, lakes, rivers, and rice paddies of Africa, South America, and South Asia. Anybody who has that should be considered at risk of getting schistosomiasis. Uncooked fish, seafood, or aquatic plants or grasses like watercress is an important risk factor for those flukes. So if you have a patient with a history of liver disease and exposure to one of these things, including aquatic plants and grasses, which are a common source of food for Asian populations, think liver flukes. And any food or water in a warmer climate with poor sanitation. So think your travelers that are coming back from sub-Saharan Africa, from Southeast Asia, from Asia, where they may have been drinking water that was not treated properly or where there's poor sanitation, Entamoeba histolytica. So moving away from those exposures to symptoms and signs of parasitic liver disease. And I'm going to divide these into acute and chronic. Acute infections, or the invasive stage of parasitic infections, are not commonly seen, but when they are, they're typically seen with fever, often very high fever. Eosinophilia in the case of helminths, so those worms, or neutrophilia in the case of protozoa like Entamoeba histolytica. Severe upper abdominal pain. Usually the liver flukes that migrate through liver tissues cause severe abdominal pain during the acute presentation. Dysentery, of course, with entomobiasis. Jaundice can occur as the liver tissue is destroyed by the migrating parasites, and hepatocellular enzyme elevations for the same reason. Those chronic infections present quite differently. Usually you'll see it as an upper abdominal discomfort, sometimes associated with symptoms of biliary obstruction. You might see mass effects in the case of a large cystic mass in the liver. Cirrhosis or pelvic organ scarring from schistosomiasis, when you've got a lot of severe scarring relating to egg migration through the liver. Certain cancers are triggered by parasitic infection. So if you've got somebody, for example, with a bladder cancer or colon cancer who's quite young and has had exposure to schistosomiasis, think that there might be an underlying cause there. Often there is no eosinophilia or neutrophilia in cases of chronic infection. Once you've suspected a liver disease based on history, some of the investigations become more important. Of course, a complete blood count. You want to get that differential. You want to see if there's eosinophilia. It is an important sign of a tissue and liver infection. Liver and abdominal imaging is extremely important. Any of those cystic elements are going to be seen mostly in abdominal imaging. You're going to want to get your stool and parasites, your biochemistry. Ultimately, the diagnosis will often depend on tissue examination, pathology, cytology, or microbiology, and some limited specific tests like Entamoeba histolytica antigen or PCR. Your chronic infections, serology becomes important because you can detect antibodies to certain parasites, which are important contributors. But remember that serology is usually positive for life, so it doesn't necessarily tell you that it's a recent or even relevant presentation. Your liver function, your albumin and clotting factors in suspected cirrhosis, if you have somebody with schistosomiasis that's chronic. And of course, endoscopy and portal imaging to make sure that you're not dealing with somebody with advanced portal hypertension or cirrhosis. Now we're going to dive right into those 4 parasites. I'm going to talk initially about schistosoma species. This is one of my favorite parasites. It's awful for the people who have it, but I'm one of the few people in Winnipeg who has any expertise in it, so I see quite a lot of patients with it. It is acquired by exposure to fresh water with a specific intermediate host that's there, and those are snails. It is quite geographically limited by those snail hosts. That's why you cannot get human schistosomiasis from lakes and rivers in Canada. There are 3 species that cause most of the human disease: Schistosoma mannsoni, japonicum, and hematobium. And they all can cause liver disease, but mannsoni and japonicum have a much greater preference for the mesenteric veins of the intestine, which of course drain to the liver. So you've got considerably more liver pathology with those 2 species. The damage itself is actually not caused by the worms. It's caused by the eggs. The egg is essentially produced when there's a male and a female present inside those blood vessels that you've acquired through swimming in fresh water. And the eggs will migrate through tissues to try to find the lumen of an organ, usually the intestine or the bladder. And that's how they get back into the water source, through the feces or through the urine. And when they migrate through those tissues, they cause a granulomatous reaction and inflammation. And that's what leads eventually to cirrhosis, because the wayward eggs that run through the liver and other tissues cause scarring and damage and cirrhosis. Just to summarize the life cycle, nobody really likes life cycles, but I'll make it very, very straightforward. Human that is infected will excrete eggs in the water, whether that's through feces or urine. The eggs will hatch in the water, form a structure called a myrcidium that infects the snails, and they evolve through the snails to create cercaria. The cercaria will penetrate human skin. It'll migrate in the bloodstream till the adults find their way to those veins that they like, whether those are around the intestine or the pelvic veins, and start to lay eggs. And they migrate through the tissues to end up in the environment, but also cause all that scarring on the way by. So if you remember that life cycle, you'll better understand how schistosomiasis causes the disease that it does. I'm going back to the geography here. The geography, critically important. These are the countries in which we find schistosomiasis in a heavy amount. Many of you have migrants from sub-Saharan Africa. In Winnipeg, we have a lot of migrants from the Philippines where there's a lot of schistosomiasis. But remember that you'll not only need to be exposed to those geographic areas, but also to fresh water in those geographic areas. So people who don't live next to rivers or rice paddies or other bodies of water cannot get schistosomiasis. Presentation. Acutely, you'll almost never see it. Very rarely, there'll be a cercarial dermatitis. That's when those parasites penetrate the skin after exposure to fresh water. Very rarely, you'll get an acute presentation when they're migrating through the bloodstream, which is characterized with a high eosinophilia and fever. Most of us will go through our entire careers without seeing this. I want to make sure that you guys are aware that there is a contrast between swimmer's itch and cercarial dermatitis. Swimmer's itch is a common presentation we get in fresh water here in Canada, all over the world, which is caused by a schistosome, but it's an avian schistosome. It does not cause a chronic human infection. It dies in the skin, but it does cause an itchy reaction in the skin. Much more importantly is the chronic infection. Basically, the eggs will travel through any tissue that they find themselves near to and cause scarring and damage to those tissues. So hepatosplenic is by far the most common because of where these parasites end up living, but you get hepatomegaly and cirrhosis, fibrosis, pipe stem fibrosis, which is a specific kind of periportal fibrosis, portal hypertension, ascites, GI bleeding, hemorrhoids, etc. So all those complications of portal hypertension. But you can get disease all over the body, gastrointestinal, urogenital disease. It's a major cause of infertility in Africa, a major cause of pelvic inflammatory disease in Africa, ectopic pregnancies, bladder carcinomas. And even some eggs can end up going to the bloodstream and leaving the GI area and ending up in ectopic sites like the brain. So you can get cerebral schistosomiasis and cerebral and transverse myelitis, paralysis, things like that. So anywhere the eggs end up, they can cause disease. Just some images to illustrate the level of cirrhosis that you can get. Even children can be badly affected by this disease. The histopathological images show various granulomatous tissues with egg granulomas inside them, characteristic of the kind of inflammation you see with schistosomiasis. Now, the diagnosis, of course, once again, with many parasites has to start with clinical suspicion. If you think you have it, you need to investigate it more. You'll almost never see the acute cases of this infection. Screening can also be done through serology. This is recommended for immigrants from high endemicity areas of Africa. Alternatively, you can do preemptive treatment of those individuals. Currently, the recommendation is to do serology. The lab diagnosis is dependent on microscopy in urine and stool, rectal scrapings, or histopathology of affected tissues. More so, though, we use serology in compatible clinical presentation. Remember that serology is positive for life, so you cannot rely on it as a sole source of information. The sensitivity is quite good at 96%. It is frequently used for non-endemic exposures, travelers and expatriates, simply because of low burden that's usually not positive by microscopy, and also because serology is not necessarily relevant for ongoing infection. I want to touch on one new diagnostic test. We don't get a whole lot of new diagnostic tests or new treatments in parasitology, so this one was good to hear about. There is a new schistosoma antigen that is a highly sensitive diagnostic method. The circulating antigen and circulating cathodic antigen, anotic antigen and cathodic antigens can be used for urine or serum, and they do indicate active infection, which is the beauty. So after treatment, they revert to negative, and they're not positive in patients who have burnt out or old infections. So the antigen titers correlate well with the disease intensity and the clinical severity. The problem is it's not yet widely available. So I'm hoping over the next few years, it'll become more available. Treatment is very straightforward. The beauty of schistosoma and why I like it so much is as long as you don't get to the severe damaged states, praziquantel is highly curative. So 20 milligrams per kilogram BID times 1 day, or 30 milligrams per kilogram for schistosoma japonicum. I always give a second treatment 2 to 4 weeks afterwards, particularly if it's a relatively recent exposure. But I essentially do that for all of my patients. The drug is very well tolerated and it does improve cure rates. Artesunates are experimentally active against early stages of the parasite, but not used clinically at this time. The second parasite I want to touch base on is echinococcus. Echinococcal disease is acquired by accidentally ingesting the eggs that are in the feces of dogs and other canids, typically, or bears. The eggs are ingested by the human. The human is an accidental intermediate host, so they hatch inside the stomach of the human. The larvae migrate into the liver and insist to form a hydatid cyst. These multiply very slowly over a number of months to years to form a larger and larger cyst, which is usually asymptomatic and ultimately is only detected once there's a significant mass effect. There's two forms of the disease: cystic echinococcosis, which is caused by Echinococcus granulosus, and then alveolar echinococcus, which is much more severe. Its life cycle involves a sylvatic cycle, so it involves foxes and rodents. This is a much more serious form of the disease because it is highly invasive. It is much more like a cancer. It is not encysted as well, and metastasizes and invades nearby tissues. Pathology, as I said, is mostly caused by the mass effect or the occasional rupture of the cyst, which releases a lot of antigens and causes anaphylactic shock. Worldwide distribution, most of the world is affected by one species or another. Even Canada has Echinococcus granulosis and Echinococcus multilocularis. We see regular cases here in Manitoba of both types. And Echinococcus granulosis in Canada is actually a closely related species called Echinococcus canadensis, but nevertheless, it presents in a very similar fashion. I'm not going to go through my taxonomy slide because I'm going to try to keep it in time, but basically it says here that we have our own Canadian species of Echinococcus. It used to be called the genotype 10, the cervid strain, but it is closely related to granulosis and causes cystic echinococcosis. Clinical presentation is very difficult. It is very silent in early stages, and there's a long latency period. So we often don't see these cases until 5 to 15 years after the initial infection. They usually relate to the organ system involved. Biliary obstruction, discomfort, chest pain if it's in the lungs, anaphylaxis if it ruptures, and occasionally you get cases in the brain where you see hydrocephalus. It's usually diagnosed through imaging studies when you've got clinical suspicion, or even incidentally. And eosinophilia is very unusual in hydatid disease, only really seen in cases of cyst rupture. And so it would be very unusual to see that in clinical, as a clinical presentation. Just some imaging of hydatid disease. This is a patient I saw in Peru. There is a staging of hydatid disease, and it's important to be aware of the staging because it affects treatment. We have C1 and 2, C3A and 3B, and C4 and 5. The first two stages are active. The transitional stages as well mandate treatment, but the degenerative stages don't mandate treatment. So it is important to address which stage a patient is in before deciding on treatment. If you have a patient with a cyst and you're concerned that it may not be a echinococcal infection, diagnosis is relatively straightforward. Examining the cyst contents or the histopathology is quite revealing. You can see these hooklets inside the cyst fluid, and that is diagnostic. There's also serology, which is available, that has both high sensitivity and specificity if it's combined ELISA immunoblot assay. And the sensitivity in our Canadian strains is probably a little less, but is not actually known at this point. Treatment is very complicated, and I'm not going to go into the details of this. If you have a patient, liaise with an experienced clinician and an experienced surgeon. As a general rule, smaller cysts that are active are treated with just albendazole. They may be aspirated through a procedure called percutaneous aspiration, injection, and reaspiration, or a catheter technique. Moderate-sized cysts will usually be treated with albendazole before surgery and try to remove the cyst intact. But extensive or large liver cyst usually requires surgery and debulking and long-term albendazole. This is the PAIR procedure. We use PAIR to treat some cysts, usually the smaller ones. It's essentially aspirating the contents of the cyst and removing as much as possible with a large bore syringe, and then injecting a hypertonic saline to destroy any of the cysts, scolices that are still there, and then reaspirating it after about half an hour. It is a successful technique in many cases and essentially accelerates the degenerative stage of the echinococcal disease. Very complicated slide to summarize what I've already told you. I'm not going to go through it, but remember that treatment is based on the activity of the cyst. If they're active or transitional, depending on the size, you will either use albendazole or PER or surgery. If it's biologically inactive, you do not want to do any kind of surgery or procedure, and you will do serial imaging and determine whether or not that individual even needs any therapy. Alveolar hydatid disease is much more aggressive. It is silent in the early stages, but typically metastasizes. It is very aggressive and distributes systemically quite often. The diagnosis is usually by imaging. Serology is low sensitivity because it's not based on this species of echinococcal disease. And the main aspect that I want to highlight here is that the decision to treat or not to treat and how to treat will be based on MRI PET. The metabolically active cysts should be treated, and the metabolically inactive or degenerate cysts are generally not treated. MRI images. This is a PET MRI that tells you that this is a very active cyst and will generally be will require treatment. It'll also tell you if there's any metastatic foci of disease. Diagnosis is again by microscopy. The histopathology is somewhat different, so it does allow you to differentiate multilocularis from granulosis. As I indicated, the serology is less useful for alveolar hydatid disease. Differentiating the two is difficult, but usually the imaging with the histopathology is telling. The serology is not helpful, but PCR is also available, which will allow you to differentiate the two types of echinococcal disease. Treatment is very difficult and ultimately usually unsuccessful with Echinococcus multilocularis. It is a relapsing and remitting disease. It requires long-term therapy. Surgery is always indicated if the disease is active, and the adjunctive use of albendazole typically suppresses the expansion and allows many people to have a relatively normal life. But a lot of the time, this disease recurs, and remission is possible, but not necessarily the rule. This is another flow chart about treatment. I'm not going to go through it in great detail. Now, very quickly, in the last few slides is some additional liver diseases. Fascioliasis, or the liver fluke, is caused by Fasciola hepatica. Life cycle is excreted by humans who are infected, ends up in the water. Again, they infect these snails, different snails, but snails, where it produces a cercaria that will insist itself in water plants. Animals like cattle and sheep eat the water plants and develop fascioliasis, but humans who eat the plants also develop fascioliasis. It's very, very widespread, but most common in socioeconomic areas or lower socioeconomic areas with cattle and sheep, who are a major amplifying host. And the pathology is primarily caused during the acute migratory stage, when the larvae are tunneling through the stomach wall and through the hepatic tissue, essentially looking for bile ducts. Later on, you might get bile duct obstruction. Global distribution is very widespread. And so these areas across the world are affected by fascioliasis. But again, remember that it requires those water plants, the snails, it requires people to eat water plants and to have sheep and cattle around. So that's relatively limited in terms of the areas that you're going to find this more commonly. Clinical presentation usually caused by this larva migrating through the liver. And you can see here in the CT image that this liver is really punched out. It looks a little bit like Swiss cheese. That's the larvae migrating in this case. You have very elevated transaminases. You have eosinophilia, hepatomegaly, tenderness. This is actually quite an acute disease if you find it. Later on, after the acute phase, if patients don't present, which is often the case in developing countries, you'll see these people present with biliary obstruction, because it's a fairly large fluke and it ends up in the bile ducts, causing obstruction. The lab diagnosis is largely through eggs. There is serology that's available. It becomes positive about 2 weeks after infection, unlike the microscopy, which usually takes 3 to 4 months after the infection. So usually serology is the test of choice, but again, not widely available. And I believe they do it in Montreal here in Canada, but not anywhere else to my knowledge. Treatment is triclabendazole. So remember, this is the exception. It's really the only disease we use triclabendazole for. Nitazoxanide would be another option, and a single dose is usually curative. If they present in the acute phase, second dose can be given 2 to 4 weeks afterwards. Lastly, and I'm going to get through this pretty quickly because I think I'm already over time, unfortunately. Entamoeba histolytica is a protozoa, a very simple life cycle. In the human that's infected, they excrete through the feces cysts. The cysts end up in water. Water contaminates just about everything. And if the human drinks the water or food that is contaminated with that water, they develop the disease. The transmission is then fecal-oral. It mostly causes intestinal disease. About 97% of infections are intestinal disease, diarrhea, and dysentery. But invasive disease, amoebic liver abscess or lung abscess does occur in 2 to 3% of cases. There's over 50 million cases globally with 55,000 deaths. And a very important point for you if you're writing an exam is that other entamoeba species other than histolytica are not pathogenic. So they are just there for the ride. I've been through most of this already. Most cases in high-income countries come from travelers or recent migrants, so my traveling population gets this. Men who have sex with men certainly are at higher risk. Most cases are intestinal, very few are liver. Most risk factors for liver disease are men over 40 years of age, immunocompromised, and low socioeconomic status, and fewer than 1% will develop those unusual ectopic sites like lung or brain. This is CT images of a liver abscess. They usually occur 2 to 4 weeks, but a very important pearl is that latency may be for years. People may be chronically infected with entomobiasis with very few symptoms, just the cysts in their stool, and they can develop amoebic liver abscess out of the blue years later. Usually patients will have high fever, very significant abdominal pain, and leukocytosis without eosinophilia. Elevated liver transaminases are common. GI symptoms are not usually concurrent, so only 10 to 35%. So the question, do you have dysentery or diarrhea at the same time as your amoebic liver abscess, is not that terribly relevant. CT and ultrasound are extremely sensitive, but not diagnostic because of the similarity with pyogenic liver abscess. Lab diagnosis is not great for amoebic liver abscess. 10% of stools are positive, 25% of the abscess fluid in the liver is positive. But serology is quite good at 90%, but may reflect an older infection and may also reflect a treated prior infection. Antigen testing and PCR from aspirates is probably the best test, but not widely available. Treatment is typically with metronidazole or tinidazole or secnidazole for the invasive form of the infection. But this needs to be chased with an intraluminal cysticidal treatment, which is usually iodoquinol or paromomycin. Both need to be given to eradicate the cyst stage in the gut. So in that way, it's a little bit like those latent forms of malaria that require a second treatment. Percutaneous drainage is usually not required in most cases of amoebic liver abscess, but may be required in cases of poor response. So I ran through that awfully quickly. Sorry for being over time, and I will entertain questions at the end.
Great. Thanks a lot, Philippe. That was a great overview of a challenging topic. So congratulations. So I'll ask you to stop sharing your slides, and we will ask our final speaker, Dr. Ariane Buchan, to project her slides. As a brief introduction, Ariane is one of our infectious disease specialists at the University of Ottawa. She did much of her training in Ottawa, but did spend a couple of years in Boston learning transplant medicine, which we are now the fortunate benefactors of. Ariane is the infectious disease program training coordinator, and as a clinician and in that role, just as every day demonstrates such a high level of dedication and thoroughness, which I'm sure will shine through in her talk entitled Infections and Liver Transplantation. So take it away, Ariane.
Thank you, Curtis, for such a kind introduction. Just to confirm, my slides are being displayed okay?
Yeah, look great.
Perfect. So thanks, Curtis, for inviting me to speak to everyone this evening. I've been asked to talk about infections in liver transplantation. which is a relatively large topic for a short period of time. Essentially, I plan to do a bit of a whirlwind overview with a focus on things that are a little bit more unique to liver transplant patients as compared to other solid organ transplant patients. And I will highlight some of my favorite aspects of my job, which is a real focus on prevention of infection in patients undergoing transplantation through pre-transplant evaluation, immunizations, and we'll touch a little bit on prophylaxis. I will end with a very quick word on hepatitis B and hepatitis C, specifically in liver transplant recipients. But after Dr. Coffin's excellent talk earlier this evening, we won't spend too much time on that. So just as a brief introduction, transplantation has become an increasingly used treatment in the management of end organ disease and failure across the board, which includes liver transplant. In 2019, these are our most recent stats, as well as the transplant stats that were not affected by the COVID pandemic. We did 610 liver transplants over the course of the year within Canada. So not our most common transplant, but certainly a decent number here. It's about 10 times that which are done in the US. So they do about 6,000 each year in the United States. Survival post-transplant has improved significantly over the years, mainly due to improvements in surgical techniques and post-transplant management, as well as treatment of any kind of graft rejection. We now quote survival post-liver transplant at over 85% in year 1 and up to 75% at 5-year mark. However, infectious complications remain a significant cause of morbidity and mortality and are actually one of the leading complications post-transplant. Studies quote approximately half of all liver transplants will experience some kind of infection. This is a really nice cohort study done by a Swiss group. They looked at 6 years of transplantation, during which time over 2,700 patients underwent solid organ transplant. Of that, close to 600 patients were liver transplant recipients, so about 20% of their cohort. Interestingly, during this period of time, a total of over 3,500 infectious events occurred, and about 1,500, or half of the recipients, met criteria for clinically relevant infections. So certainly a big issue in terms of complications amongst our transplant group. Within the liver transplant population specifically, 79% of patients who underwent liver transplant reported any type of infection, of which over half were clinically relevant infections. Within the group, 725 different infection events were reported, majority of which were bacterial infections, followed by about a third of patients having viral infections, fungal infections, and a very small number having parasitic infections. These numbers matched up relatively well against the cohort in total for solid organ transplant patients. You can see here this graph just displays that of the different transplant types, the liver sits relatively in the middle in terms of infection risk, with heart and lungs being on the higher side for infections post-transplant, but kidneys being relatively lower risk in terms of the overall cohort. Looking here, this graph nicely displays the various types of infections that these patients suffered from. Looking at the bar graphs, liver transplant patients fall into the fourth group here, and certainly overall can see that candidal infections were the majority of fungal infections within the liver transplant patients. And certainly they had issues with Enterobacteriaceae infections, Enterococcus infections, and the herpes viruses as well. Now, interestingly enough, in their liver transplant patients, significant multi-drug resistant organisms within the gram-negative group are reported widely amongst many studies, and within the Enterococcus infections, VRE is certainly a real concern as well. So this just goes to show the real risk of these drug-resistant organisms in this patient population, as well as the importance of appropriate antibiotic use. This is a very classic diagram for anyone who's read transplant infectious disease summaries and articles. Doctors Fishman and Rubens were some of the founding fathers of transplant infectious disease, and it's hard to escape a presentation or a summary article without seeing this kind of timeline. Essentially, it breaks down the risk as time progresses post-transplant. The first month being the most significant for nosocomial or surgical site infections. And certainly this is a significant issue in the liver transplant population. As well, during this time period, donor-derived infections are a real consideration. Once we reach the 1 to 6 months, this is the time that we really see the immunosuppression risk kick in. More concern about opportunistic infections and reactivation of latent infections occurring during this time period. And once patients progress to 6 to 12 months or further out, we start to see an increase in community-acquired infections. So things that we would expect in our typical host, pneumonias, viral pathogens, as well as there can be late presentations of viral infections and other opportunistic infections, especially as our standard prophylactic protocols come to an end around this time period. Everything has been updated as time goes on. So this is a bit of a newer infographic put out by Fishman in 2017, in which case it really does highlight a little bit more detail exactly the timelines of these very specific infections. Again, indicating the first month post-transplant, we see mostly nosocomial, technical or surgical associated infections and donor-derived infections. And as we move out from transplant, hitting that opportunistic infection middle ground, and then moving more towards community-acquired infections. In terms of what contributes to the risk factors for why these patients suffer from infections, we can really break this down into 2 big categories. So epidemiological exposures really is a comprehensive way to think of a lot of things that both the patient and the recipient, the recipient and the donor may have been exposed to, as well as thinking about nosocomial and community-acquired infections, as well as infections that can reactivate once patients face immunosuppression. And then we also think of this net state of immunosuppression. So not only the patient's immunosuppressive regimen in terms of induction and maintenance immunosuppressive therapy, but also host factors of immune function, chronic or underlying diseases that can contribute to this, the transplant type and the process. So how long was the surgery? Were there complications during the OR, the warm and cold ischemic times that the organs faced? Invasive devices in foreign bodies, catheters, any kind of drains, PICC lines, those types of things that these patients who have been in hospital for a significant period of time might have can certainly contribute to that net state of infection risk. And then certainly within the transplant group, we worry about immunomodulating viruses. So CMV is a big risk factor for other infections in this patient group. In terms of immunosuppressive regimens, I'll just breeze through this really quickly. Most of our patients have induction immunosuppressive regimen at the time of the transplant or the OR. Many centers will use ATG or thymoglobulin, which is a T cell agent. Some centers will use alemtuzumab and basiliximab, depending on the transplant type and the local protocols. And then all of our patients will end up on a combination of maintenance immunosuppression. Most typically, this involves calcineurin inhibitor or mTOR inhibitor, plus an anti-metabolite, plus steroids, which gets tapered to a lower dose of prednisone over time. And then the other important factor to consider when we're discussing transplant infection risks is any treatment of rejection. Both the rejection itself can lend itself as an infection risk factor, but more so the reinduction immunosuppressive therapy that these patients might be treated with essentially resets the clock back on that timeline and risk for infection as we think about the infections that these patients might face, as well as the prophylaxis that they may benefit from. We'll breeze through this just for the sake of time, but that just details a little bit more about the different effects that these agents have on our immune system. And then in terms of things that are unique to the liver transplant, really this group does have some unique factors that play a role in the infection risk. Certainly these surgeries can be more prolonged. Some of these patients end up requiring large amounts of blood products or transfusions during the time of the OR. So anything that's over 40 units of transfusion puts these patients at higher risk of infection, especially fungal infection. The various types of surgical procedures and how the surgeons and the technical aspects of entering the bile duct and what drainage may have happened during the OR can play a role in the risk of infections and intra-abdominal infections that can develop. And certainly patients who undergo repeat transplantation are at higher risk of infection. As with all solid organ transplants, CMV infection is a risk factor for other infections. For liver transplant patients specifically, those who end up with renal failure and end up on renal replacement therapy puts them at higher risk of infection. The unique aspect of these patients being sicker going into transplant, potentially needing hospitalization, severity of their underlying liver disease and MELD score contribute to their infectious risk factors post-transplant, and their perioperative hospitalization, critical illness, and things they may have been exposed to in hospital leading up to the transplant. Important sites of infection are, of course, the surgical site, the abdomen, biliary tract, and then lungs and bloodstream are other potential sources that we see increased infections in our liver transplant patient population. Just to touch on a few specific infections, fungal infections are higher in our liver transplant patients than any other organ group. 80% of fungal infections will occur during the first month post-transplant, with 90% occurring within the first 2 months after transplant. Risk factor for fungal infections include many of the things I've already gone through, but certainly elevated creatinine and requiring dialysis or renal replacement therapy, long ORs with multiple transplant procedures, hepatic iron overload, and then baseline colonization with Candida predisposes patient group to these fungal infections. Patients may also have been on more prolonged broad spectrum antibiotics, and certainly CMV also plays a role. Here is just a quick infographic showing that really what we see in the liver transplant patients are almost most significantly Candida infections. This comes from a US database registry. Candida is the predominant pathogen, so up to 60 to 80% of fungal infections in our liver transplant patients will be with a Candida organism. Risk factors, again, very similar to what I previously discussed. And the invasive candidiasis infections certainly are at higher risk of mortality compared to our non-transplant population. 1/3 of patients will have a non-albicans candidal infection, which may be increased by the use of prophylactic fluconazole in this patient group. So certainly we do worry about azole resistance with our glabratas and our cruzi. Aspergillus is another or next most common fungal infection, although the rates of this are quite a bit lower than what we see with candidal infections. 1 to 8% of liver transplant patients will experience an invasive aspergillosis infection, and more unique to liver transplant patients is that these infections can be disseminated as opposed to single organ infections. Certainly they can develop early post-transplant, but at about the 3-month mark is when we can also see increased risk of aspergillus infections. And then I think it probably will come as no surprise to anyone in the audience, abdominal infections in terms of bacterial and source of infection will be our most common in the liver transplant group. Again, mostly related to surgical complications and how the liver transplant has affected the bile duct and any involvement of the GI tract. We see liver abscesses, cholangitis, peritonitis, and intra-abdominal abscesses, which all need to be investigated and managed appropriately. So I'm just going to switch gears after just going through that brief overview of infection risk in this patient group to talk a little bit about prevention of infection. There's a pre-transplant evaluation that gets done in most centers who perform solid organ transplants. I do a fair amount of this with our patient population in Ottawa, and so often think of a bit of a checklist in my head of what I like to go through, which is really widely accepted, reading the literature, especially guidelines put out by the American Society of Transplant and other significant transplant societies. Really important to establish a medical history of infection, including latent infections in this patient group. Antibiotic exposures is certainly helpful, especially with regards to establishing any allergies. I really do like to clarify penicillin allergies, as that's such a basis of empiric antibiotics that we use for these patients. And so with being able to use the beta-lactam antibiotics really does help us. And then a very thorough exposure history, geography, travel anytime within the lifetime is certainly something that we ask about. Home exposures, including who's at home with them, pets, things they do around the house, hobbies that might take them outside, animal exposures, certainly going through occupation, over the years that I've been doing this, people forget that travel for occupational reasons, especially involving military work, can sometimes get forgotten. So making sure that you've established travel for fun as well as travel for work purposes. And then sexual history, substance use, as well as any specific risk factors for certain types of infection, with tuberculosis being a really important one to be able to identify risk factors for. So once we go through all of the history, discuss exposures, then we can do a review of the data that's available. So having a good understanding of past microbiological results, especially with regards to drug-resistant organisms, is important for our empiric antibiotic use when or if these patients become septic post-transplant. A whole slew of screening tests would be reviewed, and based on much of the serology that is standard procedure, as well as what we would add based on exposure history. And then going through immunization records to make sure patients are up to date is another important part of this pre-transplant evaluation. Just going through very quickly, most transplant centers will have a standard protocol of what gets sent off and all of their recipients. To highlight things that are especially important for the liver transplant patients would be viral hepatitis. Hepatitis A is not necessarily a standard or necessary test, but it's important for me to know with regards to protection of the liver from vaccinations with hepatitis A vaccine. Hepatitis B and C, of course, are tested for. With any antibodies that are positive, we go on to do PCR testing to understand viral load or active circulating virus. Things that require live virus vaccines are helpful to test for, because this would be the opportunity to get these patients vaccinated appropriately before they become immunosuppressed. Identifying latent infections so that those can be treated in advance, syphilis, tuberculosis being some of them. And then, of course, our EBV and CMV status is really important for risk as it relates to how they match between the recipient and the donor. Additional screening that I always go through based on history. Endemic fungi, we certainly have been seeing a lot more of this within Ontario and the Ottawa Valley area. We're seeing a lot of histo and blasto, but interestingly, there's not a lot of data to support that these are big risks in terms of fungal infections that reactivate post-transplant. So there's not a lot of general consensus or recommendations that we need to screen for these before a transplant. However, in the Southwest United States, this is different with coccidioides, which certainly is known to reactivate post-transplant. And therefore, the patient population in that area will be screened and prophylaxed accordingly with fluconazole. Along the parasitic line, after our last talk, strongyloides is a really important one to screen for, which has the risk of reactivating post-transplant or post-immunosuppression. Therefore, anybody with significant epidemiological risk factors should be screened and treated with ivermectin before undergoing transplant. We think about trypanosoma for Chagas disease, mainly in our heart transplant candidates, but certainly patients who have received a liver transplant who have a new diagnosis of cardiomyopathy, that might be something that we would consider. And schistosoma is not a big one that we see reactivating post-transplant, but certain centers will screen if there's been a significant travel or exposure history pre-transplant. In terms of preventing infection, a large way to do this is to make sure our patients are up to date with their immunizations. So vaccine preventable diseases are a significant cause of morbidity and mortality amongst solid organ transplant patients. As much as we know about the importance of vaccines, the uptake of them pre-transplant is a little bit hit and miss depending on where we look in the literature. And so there is some work to be done in terms of making sure our patients are up to date with recommended vaccines. Many centers are adopting checklists or recommendations where these patients will go and have their vaccines before a transplant. We tend to try and recommend the immunizations are done pre-transplant. Ideally, this would be the time when we would see that they would have better efficacy. However, many of the non-live vaccines are totally appropriate to continue on with or give boosters post-transplant. Travel-related vaccines, I won't go into just given our time limitations today, but they should be addressed per destination or itinerary. So patients should be counseled that any trips should be reviewed with their transplant specialist or a travel medicine specialist before taking them. But in non-liver transplant patients, I do tend to make sure that patients who might be frequent travelers are up to date with hepatitis A vaccine prior to transplant. In terms of basic immunizations that we always go through, so influenza vaccine should be given to all of our patients annually. We can start as early as 1 month post-transplant. The group in Toronto has done a lot of work looking into influenza vaccine in the solid organ transplant group. For liver transplant patients, anything to reduce subsequent injury to the liver and the new liver is really important. So making sure these patients are up to date with hepatitis A and hepatitis B vaccines. The one thing I will say about hepatitis B vaccine is that in order to make sure our patients are fully immunized pre-transplant, often centers will use an accelerated schedule, so giving all 3 doses over a 2 to 3 month period, in which case we often will check serology and see if they need boosters, and frequently we'll use a higher double dose 40 microgram vaccine for these patients. Pneumococcal vaccines, making sure our patients are up to date within the last 5 years with both Prevnar and Pneumovax. Tend to build this into the schedule as long as there's 8 weeks between the two. And then all of our transplant patients should have had at least 1 dose of Tdap or Adacil within their adult lifetime, and subsequent boosters can be given with tetanus, just tetanus boosters alone. And newer since 2018, we're now using much more Shingrix, which is the inactivated varicella zoster. We're giving this to a younger age group in the pre-transplant population compared to the general population, given the benefit for preventing varicella reactivation in this patient population. And same as with our regular hosts, they get 2 dose series, preferably pre-transplant if possible. Certain vaccines are really only indicated if there are other risk factors. So considering patients who are undergoing transplant, but also might have asplenia, certain types of patients who are highly sensitized may get specialized types of immunosuppressive therapies, which put them at higher risk of meningococcal disease. So they should be vaccinated against meningococcal disease. And HPV is one that we typically think about in the younger patient population, but I do tend to broaden this scope with the patients that I speak to, and try and do the 3 dose series of HPV vaccine before the transplant when possible. Live virus vaccines are generally contraindicated post-transplant. This is a topic that is of interest in the research world, and certainly some of our pediatric transplant ID colleagues are starting to do some research with regards to varicella vaccine in post-solid organ transplant pediatric patients. We're not quite there yet with adults, but I do think that this may become an area that gets reassessed pending results from pediatric studies. At the moment, we generally would not give this patient group any live virus vaccines. Thus, the pre-transplant evaluation time period is the time to do it. So checking serology, and if our patients are non-immune to measles, mumps, rubella, and varicella, as long as there's a 4-week window before transplant, I go ahead and give those live vaccines. And of course, our COVID vaccine. So very briefly, recommendations have come out by the Canadian Society of Transplantation. It's recommended that our patients have 3 dose primary series of their mRNA vaccines before transplant if possible. However, if patients are not able to complete the full series before they go for transplant, they can restart the series as long as they are 1 month post-transplant, regardless of induction immunosuppression. However, if they have received any rituximab, then they should wait 3 months post-transplant or post-rituximab use. Our transplant patients are eligible for a 4th dose booster. So really, we now think of that 3 doses for our transplant patients as the primary series. They do get it at a shortened time interval compared to the general population. And the 4th dose, which can occur again at the 3 months mark, is really their booster shot. In terms of other ways to prevent infection beyond immunization, so prophylaxis, I've targeted specifically just a quick overview for liver transplants, as certainly the prophylactic cocktail really does depend on organ transplant type, the induction immunosuppression used, the timing post-transplant, and any other risk factors which includes donor recipient serostatus for a lot of these infections. Very briefly, my checklist to think about what these patients should be on would be being on pneumocystis prophylaxis. So liver transplant patients will get 6 to 12 months standard prophylaxis after transplant. There are some centers that have had outbreaks, so occasionally we'll see centers restarting septic prophylaxis in the setting of an outbreak. In some countries that have had multiple outbreaks, I'll even opt to use lifelong prophylaxis against pneumocystis. With regards to the liver transplant patients, there's been some studies to look at Candida prophylaxis using fluconazole. Generally speaking, about 2 to 4 weeks is recommended in the literature, or if they have ongoing risk factors until those risk factors resolve. In patients who are specifically at risk for mold or aspergillus infections, may want to use something more broad than fluconazole for prophylaxis. Antiviral prophylaxis really depends on CMV status. So anyone who would be at moderate to high risk of CMV reactivation will be put on valganciclovir, again, depending on the serostatus, anywhere between 3 to 6 months. The time recessed if they are treated for rejection with, again, induction immunotherapy. In patients who are CMV donor and recipient negative, then their risk factors for viral reactivation would be mainly HSV and VZV, thus they could be on acyclovir or equivalent for up to 3 months post-transplant. So there's just a little bit of extra information on the recommendations for when we would be considering Candida prophylaxis and Aspergillus prophylaxis in this patient group. And this is just a snippet for anyone who's interested in reading about CMV. My go-to resource is the consensus guidelines put out in 2018, looking at CMV disease and solid organ transplants. It's a really nice review and certainly does go through treatment recommendations as well as prophylactic recommendations. And then very quickly with the last few minutes as I try and keep on time. So just very quickly, I spend a lot of time looking at various algorithms and protocols when I get questions for these types of scenarios. But we do worry about hepatitis B and liver transplant patients. So recipients who are receiving liver transplant for hepatitis B do need to be monitored for any reactivation carefully during the time of transplant, and then every 6 months lifelong after that. Transplant candidates with a hep B active infection should be treated while they're waiting for transplantation. And any liver transplant recipient who's surface antigen positive and has not previously been treated with eradication of their hepatitis B infection should be treated with one of our nucleoside analogs. And some centers will choose to give HFIG as well. It gets a little bit confusing. We get some questions with regards to donor and recipient status. So this is specifically for liver transplant patients, not non-liver solid organ transplant patients, in which case the risk is significantly different. But patients who receive a liver from a core positive donor, surface antigen negative core positive, without receiving prophylaxis, the risk of transmission from that liver transplant has been quoted as high as 80%. Of course, with the highest risk being hepatitis B naive and non-protected recipients. This risk is significantly reduced with use of HFIG as well as use of lamivudine. There are not head-to-head trials comparing lamivudine with some of our other agents like entecavir and tenofovir. However, we're tending to use more entecavir and tenofovir these days compared to lamivudine. A lot of the older studies were done with lamivudine prophylaxis, which is where these numbers and recommendations have originally come from. And patients who are core positive themselves don't need antiviral prophylaxis universally, but it can be considered in patients who have a more intense immunosuppressive regimen planned. There's just a quick schematic. Again, this is from 2015, more based on lamivudine, but in the 2019 American Society of Transplant recommendations, moving more towards considering tenofovir or entecavir for our prophylaxis use. And then hepatitis C and liver transplant could probably be a whole 1 to 2 lectures in itself. But certainly with the direct acting antivirals, this has really changed the way that we manage Hep C in general, including in liver transplant candidates on the wait list. Ideally, we would achieve viral eradication before they undergo liver transplant. However, patients may undergo transplant in the midst of treatment, so need to be continued for at least 4 weeks post-transplant. There are some scenarios in which case hepatitis C treatment may be opted to defer until post-transplant, which opens the door up to the donor pool of Hep C NAT positive donors with the plan to treat post-liver transplant. So there are certain patient populations that liver transplant centers might consider this scenario in. And so I think I've caught up a little bit on time, but I will stop there and happy to answer questions as part of the panel discussion.
Great. Thanks a lot, Ariane. And to the rest of the speakers, we covered an awful lot of territory this evening. And it was done expertly. And I think we probably mentioned every infectious disease known to humankind in the last 2 hours. We do have a couple of minutes left, so we will finish on at 9:30 as advertised. But I'll ask the panelists to show your video so we can all see you. Thank you. There's been a couple of questions that have come from the audience. So what we will do is I'll start the questions. I thought, how about we'll start with Marco. It's an hour and a half since you last spoke. So Marco, I'm glad you're still awake and with us. Can you maybe talk about the interaction between the gut microbiome and NASH and alcohol liver disease?
Yeah, I mean, it's an excellent question. Certainly I suppose a very relevant topic considering this infectious disease forum and the connection to the liver. I mean, it's really an area of great interest. Number one, I mean, I think the microbiome certainly plays a important role in the development and progression of many liver diseases, alcohol for sure, and probably NASH as well. And then, so by extension, then understanding the role of the microbiome, the differences between, the differences between the features of the microbiome that might predict sort of progression of one person versus another, and then figuring out ways to target the microbiome, which is already happening. Lots of studies in liver diseases across the board, cirrhosis, but also, to your point, alcohol and NASH, about probiotics, prebiotics, for example, fecal microbiota transplant. So I would say it's all sort of, in a nutshell, very, very early, but certainly an area that, as far as I'm aware, is garnering more attention. Every meeting, you're seeing more and more presentations in this regard. So I really do think it's an area that we could and should be focusing on for prevention and prevention of progression, probably, to liver disease.
Yeah, there are some dramatic animal models where the changing of the gut microbiome has a huge impact in either producing NASH or resolving it. So it'll be interesting to see if we can ultimately achieve the same outcomes in humans. So next question for Carla. Why are we having such a hard time creating a hepatitis C vaccine? Is it just because we're not investing enough in that pursuit?
Well, I guess, you could argue that when you look at the efforts that went into the COVID vaccine, maybe if they put the same amount of effort into Hep C vaccine, then we'd be in a better place. But I guess that's a different question. I mean, I think I read an editorial about this study, and they said that the authors should certainly be really congratulated for doing it. I mean, it was extremely difficult. It took 6 years to recruit, and yet they still did get over 500 people. It's a very difficult population to recruit. I mean, persons who are, with a history of injection drug use. And yet, despite that, they didn't show a benefit from the vaccine. Maybe it could do with the vaccine design, and I'd be interested to hear any immunologists in the meeting about what their perspective on using the adenoviral vaccine. Maybe it was because they used the non-structural proteins rather than the envelope proteins in the vaccine design. And maybe for future studies, which they proposed, is that they need to do these controlled human infection studies, which, I think I can imagine. I can only hardly imagine the logistical and ethical challenges with that. I don't want to jump or change the topic, but I do want to clarify something about the hepatitis B trivalent vaccine, which somebody in the audience kindly corrected me. I'd said that it was 2-dose, and that could be a possible benefit for compliance or adherence. But that 2-dose regimen was actually only studied in a subset of the population. So in the study where they were comparing the new Hep B vaccine formulation, both of them had the 3-dose regimen. It was only in a subset where they said it was a potential benefit from 2 doses. So just so that I wasn't misleading the audience about that study.
Good. Well,
Yeah.
my belief that you were perfect has now been shattered. But thanks for clarifying that.
Thank you.
Next question, mainly for Philippe, but maybe Marco or you, Carla, might have some thoughts. What, if any, role is there for ERCP in diagnosing fluke-related ductal disease? And that this is in the context of a chronic obstructive liver disease, and I really have a hard time trying to figure out whether it's a fluke or not.
Well, hard to answer, because a lot of the time you just find these incidentally when you're dealing with an obstructed duct. The ones that live in the gallbladder can often be seen by ultrasound as a mobile mass in the gallbladder, and so that's helpful. The stool for ova and parasites is usually helpful, but as a primary tool, ERCP I don't think plays a major role, unless there's actual active acute obstruction, in which case you go in there, you examine the ampulla and you see that there's a little tail in there. Ascariasis is actually much more common as a cause of bile duct obstruction. I've even seen that myself.
I'm going to defer this question to Marco.
Well, I mean, I don't do ERCP primarily, but the scenario that came to mind was the one that Philippe just mentioned, where someone's got acute obstruction of the biliary tree, where they're going to have an ERCP anyways. And then, I remember in medical school flipping the page to the Ascarius picture with the tail or the worm hanging out of the common bile duct and having nightmares. So that's my limited exposure to it.
It was a very scary.
It was a very scary, exactly.
Okay, next question for Ariane. So you see liver transplant patients, you diagnose them with a CMV disease, you start them on antiviral therapy and you suppress the virus. Couple of questions. When do I know that I've treated them for long enough that I can stop it? And when you go by the cookbook, you treat them for this long and then you stop it. They haven't yet, but you haven't changed their immune suppressive milieu at all. And most of the time it doesn't come back. And I've always kind of found that, why isn't it coming back? Is it purely because the immune system has had a chance to recover from the transplant? So I realize that's a poorly formulated question.
Curtis, you're going to have to come do clinic with me. I get the recurrent CMVs all the time. So in terms of treatment duration, with regards to CMV viremia, I would always treat until I see 2 consecutive negative tests. So ideally, I would get to non-detectable. Occasionally, and depending on the lab that the PCR testing is being done at and which machine that they're using, you'll get a level that is below the level of quantification, but is still detectable. Those can be difficult to interpret because occasionally you'll never reach a fully non-detectable level, which is ideally what you would want to see. At which case, if I've been stuck, so for example, our center detects at 137. If I get stuck there, I might consider stopping earlier if I don't reach an undetectable level. If they have end organ disease, so GI involvement, we often go for a little bit longer and for more set durations. People who are lucky and don't have recurrent CMV, like recurrent infections, may have developed immunity and are able to keep it in check themselves. So the group in Toronto has done some really interesting work on CMV, cell-mediated immunity. So looking at basically IGRA tests, so similar to what we would do for TB, to CMV, and it's actually looking like it's predictive. So patients who come to the end of their prophylaxis period and have a positive CMV cell-mediated immunity assay have a much lower chance of developing CMV viremia or reactivation moving forward. Those who have not established cell-mediated immunity are at higher risk, and so in those situations, they may benefit from extension of their CMV prophylaxis. So that's not yet standard of care or practice that we can use at the moment, but I think that's where this will be heading as these tests become more studied and more available. I certainly have a handful of patients who reactivate, so they'll have been treated, they'll fully go away, and they'll reactivate later on within a couple of months. In those situations, the first step I do is try and have the transplant team reduce the Cell-Ceptor mycophenolate. That seems to have the biggest improvement in terms of patients being able to control the virus on their own. And if despite this, they keep reactivating, there's no guidance documents or specific scientific evidence. But often if you end up with kind of 2-3 recurrent infections, giving them some post-treatment prophylaxis is a reasonable approach. CMV is known as the troll of transplant infectious disease. There's a good reason for that. It can be really challenging to manage.
Great, thanks. And thank you to the audience for continuing to submit their questions. Another one for Ariane, maybe you can quickly try to address this one. Are there any specific bacterial pathogens that seem to be more common with liver transplant compared to other solid organ transplants?
So certainly it's a patient group that there are studies to show increased multi-drug resistant organisms. So there are more Enterobacteriaceae and gram-negatives that are drug resistant, Klebsiellas and some of the E. coli's. Certain, again, geographically dependent on which centers, maybe less so in Canada and more so in the US, but carbapenem resistant organisms are certainly seen quite a bit more frequently in our liver transplant patients. And then Enterococcus, and alongside that, the VRE would be ones that we'd be concerned about. So mainly GI pathogens, things that would commonly affect the biliary tree would be the bacterial pathogens that we would be most concerned about.
Okay, and maybe I'll leave the final question to our illustrious president, Shara Cater, and this is for Marco. Apparently CCR5 inhibitors may have a role with NASH. Can you expand on that at all?
Yeah, they're in later stages of clinical trials, and I mean, tend to have a sort of anti-inflammatory, potentially anti-fibrotic mechanism of action. So there were some positive, earlier phase results, and so one of the many sort of molecules that were, that we should be getting readouts, later phase 2 and then now phase 3 trials. So to my knowledge, I'm not aware of a phase 3 readout for that molecule. Senecra-Viroc, I believe, is the name that you're referring to. But again, one of the many drugs coming down the pipeline that may play a role, but certainly not established as of yet.
Okay, good. Well, you know what? I think we could probably spend another 2 hours talking about all the interesting stuff that we've covered tonight. But I guess it's time to get on with our lives. lots of people I'd like to thank. I'd like to once again thank AbbVie for their support this evening. Thank you to Tracy Reed, who works in our CFID office. Thanks for her behind the scenes work. To the speakers who all just did such a fantastic job tonight. I really appreciate it, and spending the entire evening with us. To the audience, you guys are great for sticking with us, and I hope that you found this valuable. We do intend to post this entire session on our CFID site, so that you and your friends can go and watch it over and over again as many times as you like. Please tell your colleagues about this, which I'm sure they would find of benefit. Want to remind everybody that we are now gearing up for our major fundraising campaign of the year, the CFID Bug Run. It'll be both a virtual and an informal in Vancouver run this year. So you'll be hearing more about the Bug Run. You can go to our website. All we ask is you do something physically related. Take a picture of yourself, send the picture to us, try to raise some funds for us, and we will post all of your accomplishments on the website. And then in Vancouver, we plan to go for an informal run on the Friday morning for people who are interested. So don't forget about the Bug Run. So with that, I once again thank everybody for their participation, and hope you have a good night. And we look forward to offering future CFID webinars for your use and consumption. Good night.